So my pleasure to introduce Chad DeMott. I don't know how many people know Chad. Chad's one of our internal medicine faculty. Chad did his med school at Wayne State and then did his internal medicine residency at Wright-Patterson Air Force Base in Ohio. And he also was in the Air Force for 7 years prior to coming here. He's been with Carilion for 12 years. Chad's also the Associate Program Director in Internal Medicine and is known for his teaching. And I've had the opportunity to work with Chad some, and I really respect what he does. Chad actually rounded with Jess in preparation for this talk, but he's going to give us a talk on bedside teaching. And this counts as faculty development, so make sure you fill out your evaluation forms because it will go into accounting for the medical school faculty development needs.
Thank you. Thank you for the Okay, I think we're ready.
Can everybody hear me? Thank you for the invitation. I appreciate it. It's always nerve-wracking doing a teaching session when some of the people in the crowd you've actually taught, like Dylan I just had last month, so if I say anything bad or totally falsify everything, he can correct me, I suppose. So so that's a little nerve-wracking. But so first question, I want to get started. I want to do a couple poll questions just to see where we are. So if you do this, if you text Chad DeMott 303 to 37667, and then the question is, what is the first word you think of when bedside teaching is mentioned? So we'll do a little word cloud if you're familiar with those. Those are always fun, as long as we keep it serious and don't put crazy stuff on there, like no pens or something like that. If you have a second word, you're welcome to text it twice, so there's no limit, I don't think. So we'll give this another 15, 20 seconds. I always struggle with these. By the time I get it entered, they're closing the poll, so. Okay, I didn't know exactly how this would turn out. This kind of helps guide the talk a little bit. I think that's interesting. A lot of people, you see, people are kind of pro it. People are, you know, maybe a little bit against it, or it's awkward, it's daunting, it's intimidating, and then you have the big time factor thrown in there. So I think that makes a lot of sense. Let me throw up another question, and we'll go from there. Okay, so the question is, the downside to fully presenting and rounding at the bedside. What's the downside? A through E. Well, you never know what you're going to get on these until you actually do them, you know. I think this is enlightening. So I think the interesting point to this is that nobody's saying there's better ways to do rounding. I thought that was fascinating. I didn't expect that. I thought somebody would say there's a better way to do rounding. People kind of mentioned some of the limitations, but I think that's fascinating. These are the things that you'll see and you'll read and you'll hear, so that's very helpful. Let me get to the PowerPoint here. So I have no relevant disclosures, number one. I had to say that. I do have a disclaimer. My experience is mainly the inpatient setting, but these principles can be applied to ambulatory settings. So if you're in the ambulatory setting, you can extrapolate, 90% of these principles. So I kind of speak from the world that I'm familiar with, but, you can easily translate these principles into the ambulatory setting. Objectives. So today I say we because I feel like I learned from these. I learned from other people. I almost say I never had an original thought. Most of the thoughts I had I took from other people or I took from other colleagues. So we will evaluate some of the literature on bedside rounding. This will be quick. I just pulled what I could find from like the 1980s, and I'll just go through it quickly and highlight it. And so hopefully it'll answer some of those questions and some of those things that you guys brought up in the poll. We'll discover a few ways to maximize bedside teaching and maybe a way to approach it. And we will integrate at least one Pearl strategy or idea into our practice. I always feel like I can be informative and it can be entertaining and a good lecture, but if something doesn't change, if there's no application, if there's no principle that you're taking to apply, it's kind of a failure, right? I mean, that's not the idea of teaching is so you kind of transform. So I learn from this too, and there's things that I do every day. I can tell you most of my stories, like I can tell you from rounding yesterday where I made mistakes, right? And then you learn from that for the next day. Okay, so that's the goal here. Those are the three main objectives. So summary of bedside teaching articles. I'm going to quickly go through this. If you want the articles, you're welcome to email me later. I'll give you all the articles, make copies for you. By no means is this exhaustive. I just try to find the best things in the medical literature that I could find, okay? So real quick, this is from University of Calgary, their Office of Faculty Development. They said basically, and I don't necessarily agree with all this. I'm just saying this is what the study found in their study population, okay? So they said works best with preparation for the learner and the preceptor. Well, no duh, right? But how many of us forget to do that, right, to prepare? Works best when expectations are given, and we'll talk about that. They said it led to increased physician proficiency, renewed enthusiasm, enjoyable and enhanced status of the physician with patients, and then feedback is a must. I thought this was an interesting enhanced status of the physician with patients. That was kind of unique to that, where the patients thought more of their physicians when they saw them doing teaching and bedside teaching specifically. From Academic Medicine 2004, this was a peer review. This is a peer viewership. So this is the peers going out and observing their colleagues, right? You talk about daunting and intimidating, and that's what they were doing. But one interesting thing they found out is that it benefits the observer. So the observer's doing this rather than saying, I'm going to critique everybody, I'm the expert. They universally came away with, I learned some really cool things. And so when I was watching Dr. Todd, like, oh, that's a good idea. Oh, I like that. And I steal other good ideas is what I, make my career in. Feedback is infrequent was what they found. There's an infinite number of effective teaching strategies. It's not a cookie cutter. It's not one way for everything. Asking skillful questions is an art, and it is, and I'll show you a little bit later on where you can go very wayward in this. And so there's not everything is Socratic questioning. I would say 75% of the people think they're doing Socratic questioning when they're not. They're just grilling them and beating them into a corner, right? So we'll talk about that. Teachers improve with age or experience. Sometimes they don't, so, but this is from this article, okay? Bedside teaching, medical education, patients by large appreciate it, okay? This is one of the big worries that you keep coming is that it's going to freak the patients out, it's going to freak families out, it's going to freak people out. Patients, almost universally in these studies when they looked at it, the patients liked it, okay? Residents fear that it is burdensome to the patients. We saw a little bit of that, it's going to make patients uncomfortable. Sometimes uncomfortable with the patient interrupting. I didn't use that word. I think they can interrupt. It's their body, it's their life. You know, I don't have any problem with that. You know, so I think it's an interesting choice of words. Patients' parents seem to have better understanding of their disease process and increased patient satisfaction. And this is, again, you look at the studies, and this is something that you see again and again and again. So I want to kind of dispel that thing that the patients or the parents get real upset and don't like this and it causes harm to the patient. It doesn't. The literature says it doesn't. ACP hospitalists, they did this set of things, which I believe when I saw in rounds, you guys did. And I'll tell you this, my little disclosure to you, I think the pediatric, the way you guys round, I think you could teach a lot of things to the internists because you guys do it probably a whole lot better than we do as a group, okay? So from what I've seen. So I saw all of this when I watched rounds. I saw geographic rounding. It's a little bit easier on a pediatric floor, granted, so I'm all over the hospital. Interdisciplinary team rounding I think is effective, especially when you're dealing with kids. It makes, but you know, it's practical for adults. Bedside rounding and using the whiteboard. I saw a lot of this. I saw, you know, it was someone's responsibility to write the goals or what's going on the whiteboard. And I feel like we do that in internal medicine about 2% of the time, right? So I think that was a real effective strategy. Teaching strategies used by internal medicine residents is teach mnemonic. This is when I spoke to some of your residents a few months ago. I talked about this. I'll mention this briefly at the end. It'll be in the PowerPoint. American College of Physicians, bedside might not mean bedside. So some people, if you ask them, do you do bedside rounding, they will say yes. And their idea of bedside rounding is I'm standing in the hallway and then I go into the patient. That's not bedside rounding, okay? That's not the definition of bedside rounding. And pretty humorous stories, and the author of this mentions, you know, grade school in New England, and of course we do the English tradition of bedside rounding. And he had about kicked them into the room to get them at the bedside. So it was a pretty interesting way they define themselves as bedside. Don't embarrass, this is really key. You see this all the time. You don't want to embarrass, especially you don't want to embarrass, period. You don't want to embarrass the resident or the primary physician taking care of that patient. Because if that resident's taking care of that patient and you ask them a question and it embarrasses them, now what's the patient thinking or the parent thinking about the main person taking care of my, you know, loved one, right? Don't ask theoretical questions of the one presenting. Okay, that goes back to that study found. I think that's good advice. Give them a little break. The attending physician on the wards, JAMA, older physicians, this is what they said, okay? More likely to round at the bedside, do physical diagnosis skills, and do radiology rounds, okay? I don't know what radiology rounds look like anymore. We used to do that. You know, you go down the radiology room, you pull all your films. Now you do them on the computer, but how often we have the computer at our fingertips and we don't look at the films, right? So, young physicians more likely to care about the system, use quality metrics, and use digital tools. See that. This one was from medical care. Technical problems explained better to the patients when it was done completely at the bedside. Tests and drugs explained better. Rounds were positive and satisfied, did not cause worry. It's important to, and we'll mention this, introduce the team, right, very important, and explain complicated terms or explain what you're doing to the patient or parent. If I say patient a lot, remember that's the world I live in. I understand that you have parents, you know, there too. You know, I have adult children. You have parents, I have adult children, so it's similar in a lot of ways. Student and patient perspectives on bedside teaching. Learners preferred either conference room presentations or combined. This is interesting. This comes back again and again. Like if you ask a student or resident, where do you want to present or where do you want to do rounds? They'll say in a conference room and then we'll quickly go see the patient or in the hallway or something like that, some combined. But they will not say bedside, right? It's, you know, it can be a barrier. Patients enjoyed bedside round teaching, again, in this article. It did not make the patient anxious, okay? Now when I say this, you might get the estimation that I do the bedside rounds with the whole group 100% of the time. I do not, okay, I do not. There's sometimes I don't. I might be dealing with an agoraphobic patient, so it'll just be me and the resident. I'll leave the group out just to calm them. So you gotta use some common sense, right? But, so keep that in mind. I'm not saying everybody mass forwards 100% of the time, but think about that. With or bedside teaching, academic medicine, barriers, declining bedside teaching skills, the aura of bedside teaching, right? When you think of bedside teaching, you think master of education, you know, the William Osler, right? at the bedside. And the truth of it is, if you don't do it, you're not going to do it. You're going to get rusty. You're going to get worse. So you kind of dispel that. Teaching not valued by the system. I think teaching is valued by the system here. I got the DIO here. I got to be careful. But, you know, sometimes it feels that way. Sometimes it feels like, you know, I got a million other things to do, and teaching's kind of takes the low road there. Erosion of the teaching ethic. Bedside case presentations presented at SGIM meeting. 88% of patients from one study voiced concern over hallway rounding, the fear of breach of confidentiality. I think that's fascinating. One patient they interviewed from this study said he was walking down the halls, he was doing his little morning exercises, whatever. I said, if you can do morning exercises, you can get discharged, you know. This was 1988, so they kept him longer. He's walking down the hall, and he said, I could about told the histories of every, you know, hallway that I went down the hallways in. And I think that's fascinating. I think another fascinating thing is if you do hallway rounds, what's the patient hearing, you know? Like if I were in the bedside and I have decent hearing at all, I'm hearing DeMott, 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 sick, DeMott, right? I'm hearing parts of words, fragments. Talk about anxiety provoking. What are they saying about me, right? So I think just going to the bedside, it's all up front, makes a lot of sense. Students and residents thought bedside rounds were slower compared to only 24% of attendings agreeing, okay? And I'll tell you from these studies, when you look at these studies, the timing, because time was the big word on the word cloud, the timing of it, the bedside rounds was the same time within a few minutes in every study of any other rounds that you wanted to do. So I think it's a misperception that we're going to be more efficient and faster by doing some other rounds other than the bedside. Because what you end up double rounding is what you're doing. If you're doing the conference room, you present the patient with the attending right there, and then you go to the bedside and you do another little presentation in some way, right? And so if you look at the timing from the studies, the timing's about the same. So, just saying. Residents and students like the conference room to explore educational tangents. Return to bedside rounds, Journal of General Internal Medicine. Time similar to other rounds again. Mixed opinion as far as educational value perceived by the residents again. And so that's a barrier, and so you have to deal with that, right? No doubt. 13, and this is a pediatric article. Parents were more satisfied with and preferred bedside case presentations. Again, you know, pediatric journal there. Attending rounds, teaching, learning, and medicine, 25% or less of time doing bedside case presentations is what I think in my world, that's probably true. That's probably true. I felt like in the pediatric world that you guys are like inverted on it. I think you're better off than we are. Learners become more comfortable with bedside case. It's like any skill. You have to practice it. So a lot of the times the residents and students, they're like fearful of presenting at the bedside. But as they get doing it, as they do it for the month, they feel better at it, right? Guys, you three that have worked with me, say yes? Nod your heads, yes, right? Okay, all right. They recognize the value of bedside case presentations. Applying athletic, I like this. If you search Gato rounds for the Florida Gators, you know, University of Florida, they did this neat thing where they had a lot like you guys do, interdisciplinary team rounds, bedside rounds, right on the whiteboard. And they did these analogies, like football analogies, where the playbook for the job descriptions. When we go in there, who's going to do what? Where are we going to be? Right? What's our playbook? How are we going to do this? And then feedback was the game film, right? When you look at the game film, how am I going to change this? Very important. Very important. Basically, a round doesn't go by when I'm rounding somebody or seeing, you know. And again, you can extrapolate this in the clinic where I'm not thinking, how could that have interaction gone better? How can I have taught? I missed showing that physical diagnosis finding, right? This constantly is in my mind, right? And it's called Gato round. So if you want to search for that, you can find that. Another one, last one, intervention, pre-round huddle, bedside rounds, nurse integration, whiteboard updates, very similar to what you guys do. Produce increased satisfaction with the patients, produce feelings of better care. So hopefully I can dispel a lot of those things that you have with that, you know, it takes too much time. It makes learners uncomfortable. It makes patients uncomfortable. It makes parents uncomfortable. I just tell you the literature doesn't support that, all right? So again, and I'm sorry for those of you that were at a lecture a week ago for the health educators, so I apologize. Some of this might be similar, but if you have comments or questions, just throw them out there. Word about expectations. I think setting expectations is the most important thing you can do for the month. I've seen rotations that just completely went awry because they didn't have good expectations. Like, when are we going to see the patients? How are rounds going to work? What is expected of me? I've seen good clinical teachers and lots of good patients, lots of good interactions, and then it was just a mess at the end of the month. And then, you know, I or the leadership of internal medicine had to step in and say, you know, what's going down here? What's broken? And they have plenty of patients, plenty of interaction. The attendings are not yelling at them, but there were no expectations. Like, I don't know if I'm supposed to admit this person. I don't know who I'm supposed to discharge. I don't know who's taking people, right? So take the time to do expectations. I'll tell you, a mistake that I commonly make during a month is that at the beginning of the month, beginning of the time with the residents or students or fellows, or if you're working with somebody in clinic, you'll give them the expectations, or your colleague will give them the expectations. But if you come in halfway through at the week, then you say, well, you know, they got that before, or I've worked with all of these residents before, so they know my expectations. I find that to be problematic, right? And I can tell you, just with a recent rotation, that I was like, I worked with all these residents before. They know the expectations, and it just seemed like they devolved into this, you know, mediocrity, stuff like that. So don't be afraid for every new interaction, every time you touch them, to go back over your expectations, right? Expectations should be agreed upon or explain why. If they don't know why, if they don't understand, it's going to be harder for them to follow. Expectations should be clear, and it should begin with the goal in mind. What's the goal? What is it that they want to learn? For instance, you know, this month I have a dermatology prelim in, you know, May going into June. She's thinking about dermatology, right? She's not thinking about internal medicine. Now, she has to take care of patients, and she's a good resident. But it's like, you know, I told, you know, Beth, what is it that you want to gain from this? And so what can we link? And so we made sure we covered dermatological manifestations of systemic disease, right? So we tried to make it as applicable for her, as helpful for her as possible. I jokingly say this, and the students know who I'm talking about. I have a student right now who's very interested in ENT, and he's a great student, right? But we're trying to link anything to ENT, like including if they got too many narcotics, you have to give them Narcan, a little bit of acid base, and we try to link it to ENT patients to make it agreed upon. Now, you can only do that so far, but at least, you know, they'll appreciate you're trying, right? So think about kind of what their expectations are. They should incorporate adult learning theory principles. And I think this is where bedside rounding is very helpful because it's active. They're at the bedside, they're practicing physical diagnosis, they're practicing, you know, going through the, you know, rhyme scheme right there at the bedside. So it's very active. I think that's one good thing with bedside rounding. Challenges and threats, this is a big one. You guys mentioned it, time is a big one, different levels of learners. And again, I'm going to fly through a lot of this to center on some things that I think are more important, and then give you guys time for questions and comments at the end. So if I go through really fast, don't fret, you can have my PowerPoint. Don't worry about it, but you know all the challenges and threats. I don't think that's a surprise. Rounding, two of the most important activities that teachers can engage in, other than rounds, what do you think they are? So this is audience participation. If you don't answer, it's going to be really awkward. What's that? Decide rounding, and don't say expectations, but what's that? Side rounding? What did you say? No, if you're not rounding, so if you're not rounding on the patient, the two activities that will facilitate and help rounds would be, so read my mind, but okay, feedback, so I would say the post-rounding activities would be one, and then what would be the other? Learning environment's very big, yep, and I think that encompasses everything, kind of all three of these. What else? If we have a post, then we have a pre, okay, did you say that? Okay, I apologize. So pre-rounding and post-rounding are very important. Preparation for rounds and reflection, feedback, how things are different after rounds, right? If you don't do that, you're going to be stuck in a rut, right? And we'll explain a little bit of this, what I mean by this. Rounding always goes better when both parties are relaxed. If you had, again, I saw this very much on the pediatric rounds, if somebody's scared, you know, they're not going to perform very well, right? And I'm just troubled by this, where I see really good attendings that are smart and have a lot to offer and can teach the residents a lot of good stuff, but the way they deliver it is so caustic and so bad that the resident, you know, I get residents in my office that are in tears, and it's just like, you know, you're equipped, the attending is equipped to give them so much good information, but how they deliver it, they feel like a beaten animal in the corner, right? And so it's hard to learn when you feel like you're being beaten, right? It's hard to get that lesson. Do you understand me? I understand it, right? And they're freaking out, right? So don't do that. So pre-rounds, rounds, post-rounding, okay? These all tie in together. You should think about all these as kind of one unit, one entity. Pre-rounding, how will rounds occur? Classroom, hallway, or bedside? I do hallway rounds sometimes. Sometimes it's a super sensitive thing and I have to do hallway rounds. They're super anxious, right? So sometimes I do that. It's rare form. Sometimes classroom, you know, we'll round real quick, go see the patients, depending on what's going on. I will tell you, one of these things that'll come in later is how much time do you have while you're doing this? One like DeMott rule is don't irritate your learners, right? So if you're going to round for 4 hours and then you got 2 residents going to clinic, one has to do something else, and now they don't have time to eat lunch. And sometimes in internal medicine, not in general medicine, but some subspecialties, they'll round past noon to 1, 2 o'clock. I mean, how to irritate your learner. I don't care how brilliant you are or how you feel. If you don't give them, if they don't eat lunch and you irritate them, they are not going to learn. In fact, they're going to hate you. So be mindful of your time, right? You can go out there and be like, oh, rounds went really well today, right? And now they're scrambling just to make a clinic on time. Now their clinic is upsetting to them. That gets transmitted to the patients in clinic, right? I mean, it goes from there. So I can see the lights come on in the faces of some of the residents in the room. So bedside rounds, again, not to rehash this, but it honors the tradition of medicine, the privacy of the patient is the focus, the physical exam, the accurate, appropriate, and sensitive presentation, and the facilitation of the learner as leader, and many, many other benefits, okay? Again, pre-rounding which patients, you might decide to split the team. On occasion, when I know I have like 2 residents going to clinic, one's off, I have a lot of patients, I might decide, hey, let's see these patients all together, right? So I might see them all together with the whole team to teach a teaching pearl. They're going to get discharged. They're sick, right? And then I might take half or a quarter and take the students and go see the rest of them while I give the residents a little bit of time to work before they have to go to all these other commitments, right? And the students love that, right? Because the students sometimes feel left out in rounds. They feel like they're kind of on the side and they're not the big, but this gives them time to shine, ask more questions, and more of a non-rush thing. So you can do this. I don't do this all the time. It's an option. I'm just throwing options out there. So center on a few teach primary points. It's not the time to give a didactic, okay? The didactics belong in the classroom or be really efficient and then bring them back for a little 20, 25-minute thing later in the day when they get their stuff done, right? But don't start preaching at the bedside and, you know, talking for 15, 20 minutes, right? For one thing, how to upset the patient. If you're in the room for a long period of time, you could upset them, right? Because they're like, you just muted my morning show, and now I'm missing my morning show, and that, you know, right? And whoever, Kim Kardashian was coming on, and now I can't see Kim Kardashian, right?
It's frozen.
Oh, that's right, because of the, yeah. That, okay. Yeah. So that'd be even worse. You know how to freak out a kid? I have kids. I have 5 kids. Yeah, how to freak them out, how to freak my 5-year-old, stop in the middle of Frozen, right? Yeah, that would do it. I can relate to that. Planning ahead does not guarantee trouble-free rounds. Mike Tyson has been credited with saying everyone has a plan until he's punched in the face, right? So I don't often quote Mike Tyson, but I think it's a pretty brilliant quote, right? I mean, the guy had it there, you know. Well, one shining point in his life, he had a you know, rash spot. But, you know, I've started rounds where it's like Dr. DeMott, so-and-so's coughing up blood, right? And it's like, okay, all the plans are out the window, you know. It's like, you got to go take care of this, we'll take care of this. You can learn from that. You can learn, you know, in the medicine world, you know, in your world, you have rapid responses and code blues, right? You can learn from that. Go watch what they're doing with that. Great. Make every opportunity a teaching opportunity, right? It might not be how you planned it in the beginning of the day, but how much medicine goes awry a lot. I had a moment like that yesterday morning. Dr. DeMott, this so-and-so is not looking so good. It's like, okay, well, you know, these other patient teaching pearls were kind of shifted toward the sick patient. And that's okay. That's medicine. That's what happens. How will you teach physical exam findings? Okay. I got to tell you, big secret, most of us feel inadequate in some way, right? So I think if you polled everybody and you said, am I above or below on physical exam skills? I think maybe for attendings, most of us would feel like there's a lot better people than us, right? We all feel inadequate in this, right? I don't know. I went home the other night with a physical diagnosis. For you students, you think I can get away from my physical diagnosis book? I went home with it to look some stuff up to be able to do rounds properly the next morning, right? So again, this is pre-rounding, right? This is what you have to do. Don't be afraid. If you don't know something, you don't know something. Maybe they know something that you don't. And they say, oh, somebody so-and-so taught me this. Well, great. Show us. Teach the whole group. You can do that. So don't be afraid. Don't let that dissuade you. Don't overburden the patient. You got to be careful about this. We want to teach physical exam, but, 19 sets of hands on the patient, right? I can imagine with little kids, if you did this to my 5-year-old, she'd freak out and probably try to bite you. She's in the animal mode these days, so we got to try to kick in. Okay, are you little girl mode or are you animal mode? We have to, animal mode, she'd bite hands right now. So don't overburden the patient, and you can kind of tell. You can look at the patient, see what they're allowing, see what they're doing. Don't forget to point out normal. You can't know what abnormal is unless you know what normal is. I think we teach physical exam incorrectly a lot of ways. We find that, oh, it's got this cool finding, let's go listen to it. I think you need to listen to, the chest 100, 500 times. And then when you hear the abnormality, then when you listen for agophony 500 times and you hear it, you'd be like, that's abnormal, that's agophony, right? But you had to know what normal was. So I think putting the stethoscope on normal lungs and hearing normal lungs is good, right? Very important. COPD lungs, that's my world. I say, well, what do you hear? I'll put a student say, what do you hear? I don't hear anything. I said, exactly. They're not moving air, right? And is their expiratory phase any different than inspiratory? I don't know. Well, listen to me. Listen to my lungs, right? Because, oh, this is a lot more diminished. Well, thank you. I don't smoke. I'm glad you picked up on that. So, right? But know what normal is. Teach for normal. Half the battle is just looking. I'm reminded of a time when I was in the Air Force where we had a patient with in dermatomyositis, and I knew that there was a lymphoma and ovarian cancer linked to dermatomyositis. And the patient was sent to dermatology, and the full exam wasn't done, right? So the dermatologist, he just like pulled up the shirt, put hands on the belly. Oh, there's a mass, right? Well, good for him, but how embarrassing for the internist that sent to the dermatology clinic that should have put hands on the belly, right? Not just looked at the skin. Make sense? Half the battle is just looking, right? Bothers me to no end when they have a DQ. They have a DQ. Well, did you look? No. And there's a bandage on it. Well, did you take the bandage down? It's like magic. I can see X-ray vision through the bandage, right? Again, just taking down the bandage and looking, half the battle, right? So keep that in mind. Read ahead. Again, most of us do not know everything. I have colleagues that are far smarter than I am, right, in many ways. And I'm often reminded of it every day, right? So I have to continually read, right? And a little secret for the students, I said, Dylan, go look this up, and educate the team. It's like you can educate Dr. DeMott too, right? So we don't know everything. It's okay, right? And so pick out a few patients to center on the teaching pearls. Teach what you know. Teach the pearls, right? Admit what you don't know. It empowers learners, right? So they know, maybe I can be like this person one day. Not that I aspire to Dr. DeMott's dumb, and I can certainly make that, right? But we can get to the next level, and we can constantly learn. I want to think of myself as a lifelong learner. I'm continually learning. One of the reasons I love my job is because I feel like a day never goes by where I don't learn something, right? And if it does, I feel like it was a bad day for me as a lifelong learner, right? I love learning. I have that fascinating mind. Like I'll get distracted by construction sites because I want to see what they're doing, looking, curious, right? So I love learning, and we as doctors should love to learn and not get satisfied with I've kind of arrived, right? Continually learn. Show them how to find answers and to be intellectually curious. You might tell them, hey, a good resource for that might be Dynamit. Look at Dynamit, it links to an article, or this guideline. Help them know how to find things through the literature. That's very helpful. Pre-rounding, how will I include all the learners on the team, students, residents, fellows? Don't leave people out. Don't make people feel like, you never want a student to go through 4 hours and feel like, well, I added nothing to that, right? You know, you want them to be part of the team. You know, you want them to experience the victory too with the patient. What else needs to be accomplished during the day? Again, don't irritate your learners, right? So they're thinking, I got to do 2 procedures and I got to go to clinic, and he keeps talking and talking and talking. And they're not hearing anything anyway. So you think you're brilliant, right? And they're not learning anything. So just be mindful of that. Again, plan your teaching opportunities. The trip to the lab. I enjoy doing this. And I think it's kind of a lost art. It's going to the lab and looking at smears, right? And looking at, I think did we do that, guys? Okay, all right. I can't remember. If they said no, I've been backfired on me. But if we go to the lab, we looked at smears, and we want to say, okay, what does schistocytes look like? What would a spherocyte look like? Where's the good part of the smear? Sometimes we spin down urines, and we look at urines. I had a moment that I looked brilliant, and I tell you I wasn't brilliant. We had a patient with glomerulonephritis, and we went down and we looked at, and they said no casts, right? No casts on this. And we went down with the tech, and we spun it down, and I'm looking at the microscope, and I see a tube structure, right, with cells in it. And I look at the tech, and I said, well, that looks like, is that a cast? That looks like a cast to me. And it was a cast. And everybody's, now I'm the glomerulonephritis expert in the division. And it's like, all I did was look, right? That's half the battle is to go look. So go look. Maybe getting a consultant. You know, like a consultant can share 5 minutes on something probably a lot more efficiently than you can. So sometimes they're ready to teach. They see all of you. They're like, let me tell you about this. Take the 5 minutes to do that. Role modeling, too, which we'll talk about. Rounding, ironically, I'm going to go through this quickly, okay? So isn't that, it's funny, it's a bedside rounding. We're going to go, because I wanted to share the most important things, I think, with rounding are what happens around the rounding, okay? 2 things you must do, and we mentioned this in these articles. Introduce the team, very important. Numerous articles, and it makes sense, common sense. And orient the patient to what's happening on rounds. What I will frequently do is I will go to the patient and I will say, listen, we're going to do a little teaching, is that okay? And they'll say, yeah, that's fine. And I said, some of this stuff you're not going to understand. Now I promise I will break it down for you, I will explain it to you, I will answer all the questions you have. And if you think of something later or nervous later, I will come back. And they're cool. You know, they're ready, you know, you can do a little teaching and mention some big words, right? Because if you don't do that, then they're thinking, this is to me, and I don't understand anything. Now their nerves go up, right? So kind of prep them a little bit, teaching the residents, teaching the students, but then here, now I'm teaching the patient, now I'm breaking it down, right? So that's what I do. I find that to be effective. I find it to be helpful. Are there still problems? Sure. Are there still times I didn't understand? Sure. And then I go back. It's okay. It happens. Teaching without teaching, simply role model. You don't have to say a word. You don't have to give a lecture. Just seeing how you approach a patient teaches a lot, right? So how you approach a patient, how to deal with a difficult situation. I had to do that yesterday. I had to tell, you know, I had to tell a 57-year-old that she was going to die, right? Not the highlight of my day. But the residents and the students need to see me doing that, right? Do I do it well all the time? No. I feel completely incompetent. I've given this talk multiple times to patients, and I still feel like I'm not capable of giving the talk effectively, right? But I have to do it, and they get to see how you do it with compassion, how you bring in the family, what support do you offer. They need to see that. You can role model without ever saying anything. How to give bad news, how you position yourself at the bedside. Dr. Todd did this really well. I'm sorry. Okay. She did this very well. Now I can praise you after I've insulted you and forgotten your name. So she did this very well. I think get in on the level of the patient. So kneeling down, sitting in a chair, right? Jeff Weiss, one of the docs from Tulane, he used to get one of those old mouse pads and throw them down and kneel on the mouse pad. I tried that, and it lasts for like 5 minutes, and I can't do that much past that, and certainly not all through rounds. I'd like to see him do it. I'd like to call him on that bluff and see him do it because he's older than I am. But just get to the level of the patient. Sometimes what I'll do, and as I get older, I can't do this as well. but sometimes I'll get like this, and I'll do this for a little bit. And I can handle this for a little bit. I can't just do this for like 15 minutes. So I'll do this for a little bit, and then I'll kind of get up. And sometimes you hold their hand, and you do things like that. So how you do this and how they see you do this is very important. Observe the team. So it might not be about you today. So maybe, usually I'll go to the right of the patient, you know, when I'm doing my physical exam. Sometimes I tell the resident, I say, listen, you're in charge today. Maybe they're right about to graduate, right? They're in their third year, and they need some autonomy. So I'm going to say, hey, you're in charge. I'm just going to be in the background. You're running it. And so you go in, and maybe you stand in the back, and you watch how the intern and the resident talk to each other and how the teaching's going on. And I just consider it a victory when the patient is talking to one of the residents. They're talking to the residents, and they're not staring at me. And they're doing some teaching. They're talking, and they're explaining the whole thing and what they're going to do on discharge. That's a victory. I didn't have to say anything. I just observed, right? So that's a really good thing to do once in a while. Correct gently. Generally, you don't want to do this in front of a group, right? And what I would say is sometimes they'll correct themselves. So if they correct, have you ever seen it where they did something or said something and they grimaced or they shook their head and then they corrected? They've already corrected. You don't need to correct them. I don't even need to give them feedback because they already understood what they did wrong and they corrected it. So I don't need to even tell them anything. Sometimes I had a patient encounter with a resident, and the resident was listening to the stethoscope through the gown, right, and a pet peeve of mine. And some of the residents were talking to, like a family member was over here, and I didn't want to say, okay, you know, you're doing that incorrectly, slap the hand, right? So I just was right there without kind of noticing, very subtle, and I took her hand with the stethoscope, and I put it under the top of the gown. She got it, wasn't embarrassing, everybody else was cool, you know, and she understood exactly right. So just correct gently. Try not to do it. Again, correct yourself in front of the team. I've gone out of rooms where I said, boy, I really messed that interaction up, right? Have you guys felt that way before? Am I only one? Shake hands. Nobody's raising their hands. Yeah, the students, like I feel like I mess it up every day, right? I got to tell you, the attendings do it too. And so I went out of a room and I looked at it and I said, let me give myself some feedback, right? I did this incorrectly, this incorrectly, this incorrectly, this could have done better, right? And they kind of laugh and they make me feel better. Oh, Dr. DeMott, you did fine, right? But that shows that, hey, I make mistakes, and here's how we're going to correct this, right? So think about that. Sometimes nothing even needs to be said at all. We mentioned that. Sometimes we just need to rephrase. Did you mean this, right? Is this what you meant? You know, oh, yeah, that's what I meant. When correcting verbally, do it in private. I think this is important. We'll talk about feedback in the post-rounding stuff. Ask questions. Keeps everyone engaged. Helps them not forget what you just taught them. Socratic questioning. I will tell you, most of the attendings feel like they're going to be scared if I ask them questions. I almost do this every month. I think I do this every month. I say, listen, I like to ask questions. Is that good? And the students like to be asked questions, right? They just don't like to be grilled. You know, they don't like, you know, a question, 1 second pause, question, 1 second pause. But they like to be asked questions because they want to show you what they know. They know about the patient. They did the research. They did the reading. They want to show you. They want to be engaged around. So I haven't had somebody say, no, I don't like it at all. So usually they like the question. Socratic questioning. Socratic questioning is not barraging your learner with a series of questions with no time to answer, esoteric questions, questions about my research, you know, stuff like that, right? So, you know, Socrates, and again, I've read a little bit of Socrates, but Socrates asks questions usually in a dialogue, and they're asking questions and they're trying to get to the truth, right? So that's what you're trying to do. So you might ask a question, and very rarely does the learner not know anything at all, right? They know something, hopefully, right? And so you're trying to just bridge that till you get to the truth. For instance, the example that I give is I'll say, what on the CBC can tell you how functional your platelets are, your bone marrow is, and not the platelet count? And then they pause and they scratch their head and they don't know. And I said, what does the RDW do on the CBC? And they say, well, that's got big red cells and small red cells, right? I said, so I'll tell you the mean platelet volume, the NPV, tells you if you have big cells or small cells when it's about the platelets, right? So I said, okay, yeah, they get that and they're following. And I said, so what do big platelets tell you? What do big platelets tell you? And they say, well, big platelets, you know, those are young platelets. Those are, you know, megakaryocytes are big platelets. I said, so what would big platelets tell you about the bone marrow? Well, you know, maybe the bone marrow is trying to do what it's supposed to be doing. They're producing big platelets. And they got it, right? So you're walking them to the correct step. It's not intimidating. You're using their knowledge and you're bringing their knowledge in, okay? If you're going to ask a question, one of these tricks I used to do was like referees would count, you know, right? Give them time to answer. Because most of us, I think studies have said, I don't know, everybody says, like, somebody 2 seconds to answer. They don't even have time to process the question before, you know, you're answering the question for them. So give them a little time. Not an infinite amount of time, or that can be very awkward, right? But give them a little bit of time. I always start with the learners. I start with the students. I tell the students this, right? I tell the students, listen, I'm going to start with you. Because you might have just read about this rare form of leukemia, right? But your resident didn't. So if I start with the resident, I ask them that question, and they don't know, and the student knew, it's going to embarrass the resident. And then the team dynamics are off a bit. I always start with the students. I march my way up, and then they're allowed to kind of bail each other out, help each other out, be a team effort. So there's a way to do this, okay? So that's Socratic questioning the way I see it, okay? Rounding, again, summarize for clarification, tell them what they learned, solicit questions for understanding. Avoid lengthy didactics, we mentioned that. Always think out loud. I do this, I talk to myself. I don't know, probably people think I'm crazy if they pull up on a car next to me. I talk to myself, I think out loud. The learners like that because they like to see how you're processing things, how you're making connections. So don't be afraid. You're outside the room, you're just talking, okay, now if we do this, then this, and they see how you're thinking. That's very helpful to learners. Much can be learned on how to approach a problem. This helps learners connect gaps in their process as well. Post-rounding, feedback is important. Feedback is not evaluation. I know, yes, I know they call it formative evaluation. But evaluation is when you assign value at the end of the rotation. Feedback is about correcting. Feedback is about showing them what they're doing and correcting it so they can be successful at the end of the rotation when you do assign value, okay? I like what Dr. Steinway, my mentor, he used to say, you'd hold up the mirror. You know, you're not making judgments, you're just showing them what they've done, right? You're showing them behavior, right? And one of my colleagues, Neil Dorsey, used to keep a 3x5 card. He'd write down stuff like in the H&Ps, like they missed this or they missed that, right? And so when you're talking about, hey, you know, in your H&P you missed this point, right? If you don't do that, they'll say, well, which one? And then you can't remember the patient, and it looks like an opinion, right? But I feel like when you do that, when you tell them, listen, I'm going to give you rapid and frequent feedback, so at the end of the month, when you've done everything that I told you to do, we will assign value to you that you will meet our expectations. That will be good, right? So that's the whole point, right? You don't want to have the, you know, I was a clerkship director before I was associate program director in the Air Force. I can't tell you how many times I had a student in my office bawling because for 6 weeks, nobody had told her that she did this thing all throughout the rotation. And she's like, if they had just told me, I would have corrected that. And she was right. She was right. I felt horrible for her, and you had to give the attending some feedback, right? Give the attendings feedback. But write some stuff down. You're not making judgments. A lot of times I'll preface the question with, do you believe that I have your best interest at heart, that I'm rooting for you, that I want you to succeed? Because if they don't, what you're about to say will not matter, right? Because if they think you're after them or what, you're not for their best interest, it won't matter. But if you do, if they believe that, and if you're believable because you've done all these things that I've talked about, right, they'll listen to you. They understand. And they'll say, now how can I do this? How can I change this? And they'll want to change. So feedback done frequently, done well. I tell the students, sometimes the students get carried away. I say make sure you can ask for your feedback and be very specific about the feedback. Say how specifically on my specifically about my presentations. But don't do that every day, or you'll drive your attending nuts, right? If you're doing it every day. But wait like 3 or 4 days, a call cycle, something like that, just so they can get a few different iterations of it. Reflection on rounds, what went well, what didn't go well, what can we change, think outside the box, how can we be creative. I made 2 of the students here carry around an iPad and take notes, and then after rounds, we send out an Evernote summary of the rounds. They told me it was fine. I don't know if it was, so they told me it wasn't a problem, like all of them here right now that I just had recently. I think it's helpful. I mean, you're talking for 2 or 3 hours and you're giving teaching pearls. Why wouldn't you want to record that and give that back to the team? It makes sense to me. So think about it. Think outside the box. 1 minute preceptor. I'm just going to pass over this. You guys know it. Most important thing I think in here is getting a commitment. Don't fill in the gaps for them. Wait till they tell you, right? Don't just say, okay, so we have a CHF. Say, what do we have? And then wait. Okay, what supports it? I think get a commitment is the most important thing on here. Snaps, you've heard of that. And then this teach mnemonic, I like this. Take advantage of teaching opportunities. Every opportunity is a teaching opportunity. Empower learners. I saw this on rounds when they got the question right, you know, fist pump, right? You know, team's excited about that. You can see how the team would gel, right, when you do that. Assume the role of leader, and that's more for the residents. Don't be afraid to step up and teach. It's okay. I tell my residents and students, listen, if you want to teach something I forgot, fill it in, right? Fill it in. Create a great learning environment. Very important. Someone said that. Again, if learning environment's off, hard to learn. You can learn in a bad learning environment. We've all had bad attendings. Learning environment is very bad. Do we learn? Yes. But you can learn a lot more when the learning environment is proper, okay? Habituate the practice of teaching. Keep teaching. Keep thinking about how you can refine things. So in summary, we explored challenges to teaching. We outlined a basic approach, pre-rounding, rounding, post-rounding, and we developed a few teaching strategies. So with that, I would love to hear, I have several minutes, love to hear comments, questions, experiences that you have. If I said something that didn't make sense, right? So who'll be first? Or if somebody's calling in, we can answer that too.
You related being an example, like forgiving bad news. How do you allow your resident to be the news giver and you watch?
Yeah.
How do you prep for that? What do you do? I find that difficult.
Yeah. So it's a trust thing. So first interaction or an intern, they've never done it before. I'm going to be the one to do it. Just watch me, right? And then what's the situation like? Because you could be in a volatile, we've all been in a volatile room, right? And that might be that they're going to have to see you do multiple experiences with that before you're comfortable with that. But if in your room where they've been prepped, patients gave their wishes, the family kind of knows, they've already seen me do it once, then I'm going to say, okay, I'm going to go in there with you. I'm going to let you drive this, right? Are you okay with that? Yeah, I'm okay with that. I feel, you know, there's a commitment, there's a camaraderie, they've built up a relationship. And then I just stand back, and if I have to fill in and explain things, I will do that. But you know, so there's a trust issue, and then it depends on the volatility. There's some things that I go in there and I mess up because it is so volatile that you can know, no matter how experienced you are, it's going to be difficult, right? And I can imagine you guys probably experience that far more than I do. Does that answer your question? Yeah. What else? Comments? Sure.
If you have a learner that makes a mistake how do you correct that person so that the group doesn't see, I mean, if you don't correct that person somehow in front of the group, then the group might think that behavior is okay. So how do you handle that situation? Not embarrassing the person that made the error, but making sure that the students aren't watching the resident do something wrong and think that that's what they're supposed to do?
Right. Good question. So it depends if it's cognitive mistake or if it's a physical mistake, like on physical exam thing. So if it's a cognitive thing, as long as no harm for the patient, I won't probably choose to correct them at that point. But I'll bring them out and I'll say, this is how I probably would have phrased that or how I would have thought through this, you know, and I'll tell them, you know, in group or in private. It depends on the egregiousness of that. But you're right, you can't have the rest of the team making the same mistake. This is probably how I would think of this. You know, so it's a gentle way to correct. If it's on exam and they're doing something incorrectly, instead of, you know, swatting their hand, right, I'll just go up and I'll do the correct way. I'll do the correct way. And they'll see that, and they'll see the correct way. That's what I do. I'm mindful of what the patient's hearing and experiencing, and then the team as a whole, if it's physical or cognitive. Does that answer your question? Okay. What else?
Here we go. I'll unmute the phones here real fast. If you're on the line and you do not have a question or you do not want to make a comment, just please mute your phone now so we do not hear your background noise.
The conference is now in talk mode.
Anyone on the line have a question?
Yeah,
or want to make a comment?
This is Mike Hart. Chad, very nice talk. I really appreciate it. I was just going to ask you, we talk about kind of a lot of the corrections you point out in terms of style. Can you comment on when you observe nonverbal things that are happening, body posturing, things like that with your team, which you worry about how patients perceived, distraction or things like that, which are many times much more powerful than verbal communication. How do you deal with that when you observe sort of what you would be concerned about, bad posture, bad physical, nonverbals type stuff?
Yeah, so great question. And so, again, that depends on the threats of the patient. So if the patient's starting to get wound up where it's endangering the patient or how they're feeling, I'm going to kind of cut in and try to take care of that because the patient's the central focus, right? If it's not, the patient's not perceiving it, but they're starting to give off a vibe that I'm irritated or something like that, let it be done and then just tell them, hey, here's what I've seen. Again, here's what I saw, this. The one example I can think of in my head was I had a resident where the order wasn't followed. The patient had a seizure, previous hospitalization. They didn't have a sitter. The sitter went out. They hit their head. And so the patient came back in, and so we wanted a sitter because the patient would get up and wander, right? And there was no sitter. And the order was in there, and so the resident was justifiably angry at the order, but you could see his body language with one of the nurses. So he's up there, and he's asking about this, and he's doing this, right? And he's like, well, he's explaining it, the nurse is explaining, he goes, well, I'm just used to when I, put an order in that it gets followed, and he's doing this. And I kind of put my hands around my resident, and I said, you know why we're concerned is because last hospitalization, they wandered, they fell, she had a bleed from a seizure, and so that's why we're concerned. So hopefully you can understand that, and they were good. And I just kind of pulled, and I didn't even have to say anything to him. He understood exactly what I was doing, right? So he's justifiably angry, but you kind of knew what to pull in and do it delicately.
So just a comment about kind of the flip side of that. Oftentimes parents will ask a question or say something, and I'll see it go completely over the team's head. And so I might when we step out of the room, I'll say, what was mom really asking? And did we really address that? Because those subtle communications are hard.
Yeah.
And I think that's for your learners. I don't do that in front of the patient, though.
Yeah.
I'll step out.
And then you'll have them go back in and address it? Yeah. That's good. Excellent. What else?
Anyone else on the line have a question?
Well, this is Mike once again. I just want to reiterate sort of the nonverbal stuff and kind of expand on what you talked about, which I think is really important, not just with the patient, but with our allied health personnel, nursing staff, x-ray techs, and everything else. I think a lot of times it's very important to, how our trainees and whatnot, how we treat our team members. Everyone's a team member, from the patient to everybody surrounding them. I think it's really important that we, through body languages, through other sorts of verbal and nonverbal cues, that we just be very cued into this, that because it can really go off the track, so to speak, if we're not really conscious about that. It kind of gets to professionalism, I guess. That's the bottom line.
Yeah, Mike, I'll tell you what I do. So with people, I treat all people the same, so then I don't have to worry about who they are, right? So if it's the CEO or if it's, custodial, they're going to get treated with respect, and I'm going to greet them. And if they make eye contact, I'm going to say hello. And so then I never have to worry about it. So that's kind of my operating agenda.
Well, I think that's my philosophy as well, and I hope that's everybody's. But I think at times in the healthcare profession, there's perceived to be a pecking order, and we don't want to extrapolate that pecking order that may be misperceived in rounds as then kind of turning and kicking the dog, so to speak, figuratively speaking, which I think sometimes can be human nature. So I think we all have to be on guard for that. And I totally agree with you. Interpersonal respect for one another, no matter what your station in life, is critical.
Great. I think we're out of time, so thank you very much. I appreciate it.
Thank you very much, Dr. Hart. And for everyone else still on the line, if you do have a question that you'd want to get to Dr. DeMott, you can always email us at outreach@carillionclinic.org and I can get them to him. With that, we're going to go ahead and disconnect the phone lines now. Thank you all very much for joining us.